And Twitter might be being a brat today. So we are live on Facebook, LinkedIn, and YouTube. Good morning, everybody. It is Friday, September 13th. Ooh, we have to give that Friday the 13th shout out. Good morning. This is Lisa Salberg. I am with you on Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. And today I am joined by Dr. Marty Maron at Leahy and well, not Boston. I always say Boston. It's Brookline or Brookline.
We're okay. It's basically Boston. We're right. I mean,
you're right in Boston. Marty, Boston. There we go. Still trying to see if I can get Twitter to go live, but they don't want to. We don't want to play with that one. Okay, I'm just going to leave.
We're 2 days. 2 days since September 11th. We usually the last couple podcasts have fallen on September 11th that you and I have done. I know you usually have a few words to say about the connection there on that day with patients. Do you want to?
Yeah, yeah, we didn't prep for that one, but yes, I don't want to say that, we all think of different dates in history of having different meaning. And on September 11th, 2001, I was super excited when I woke up that morning. The sky was a beautiful shade of blue. It was perfect. I was driving to my office with the expectation of the following things happening that day. At 9:30, I was getting a car coming from New York City to pick me up and bring me to a TV talk show. It was the Ananda Lewis show, which was syndicated throughout the United States. Duchess of York, Sarah Ferguson was going to be there, or was there as well. And my niece, Stacy, now our Center of Excellence coordinator, Stacy Titus Brown, we were going to go in and talk about heart disease in other places than white men. And specifically, we were going to be talking about sudden death in young Black athletes from hypertrophic cardiomyopathy. And we were going to have this opportunity to talk on a national level about a very important fact within HCM, that there was healthcare disparities. And as I got to the office, I stopped at Heavenly Temptations in Boonton, New Jersey for my morning tea at that time. I was an Earl Grey tea drinker, heavy at that point. And I got out of the car, and there was an airplane flying very low down Route 287. And it was very loud, too loud for a street and an airplane. And I looked up and I could see the plane flying down, like right on 287. It was kind of weird. And I could see the people in the plane. I could see them sitting in their seats. I could see them looking ahead. There was a man with short, dark hair. There was a woman with longer blonde hair. And I could see them. I could see the people. 3 days later, I would come to follow the trail of the plane that took off out of Boston and flew into the Trade Center, and how it followed 287 at a very low altitude and was the second plane to hit. And we didn't go do the Ananda Lewis show that day, and nobody talked about HCM for a long time. And the international summit was days away. It was going to be this big HCM week. And half of the participants who were coming from overseas, their planes were aborted and they were left in airports all over Europe and had to find their ways home. And we couldn't get to the summit. And your dad called me that day and he said, "What are we going to do?" I'm like, "I'll drive." And he's like, "But nobody else is going to get here." I'm like, "Got a point." So the summit was postponed by a year. The science was postponed by a year. The awareness was postponed because of the act of a terrorist, or terrorists, plural. So a lot of people lost that day for a lot more reasons than make the front page. There was a lot of other things, and we're only one thing. A lot of other things stopped. A lot of other really important initiatives were blunted by an act of terror.
Right.
And I think it's important to understand where the connections are. So.
Well said. Yep.
Yes. So that's what happened 23 years ago, and look where we are now. I want to take a moment before we get started today to the thing that's over my shoulder. If you're not watching us live on Facebook, LinkedIn, or YouTube, I have a big check behind me at my desk, and I want to tell you where it's from and who it's about. There was a gentleman by the name of TJ DeMarco who sadly passed away last August from undiagnosed HCM. And his family, predominantly from Staten Island, New York, held a golf outing down by the Jersey Shore. And it was held on Monday of this week. His wife, Christina, was present. His family members, Anthony and Nicole, really organized the event. And other family members, including Regina and the other Christina. So there's a Christina with a C and a Christina with a K in his family. Did a great job holding their first golf outing and donating over $10,000 to the HCMA to continue our work on finding the undiagnosed. So our deepest appreciation to all that participated in this fundraiser and for keeping TJ's name alive. And we're going to be telling you more about TJ in the months ahead. And I just want to take a moment to acknowledge TJ today and to thank their family for their contributions. So moving on to the theme of the month, Marty, Septal Reduction September, which means a lot different things in 2024 than it did in maybe 2020. We have more options available for relieving outflow tract obstruction. And let's get our listeners up to speed with us on explaining what obstruction is and why it's important to manage. Doctor, take it away.
Okay. So keep it simple, which is always the best, I think, approach, isn't it? The majority of patients with HCM actually have the obstructive form, 2/3. And what we mean by that is that those patients have the ability to obstruct or impede blood flow out of the heart. Okay. And the way that that mechanism occurs is that in HCM is that the people have the misconception sometimes that the blood is being obstructed by muscle, but it's not. It's actually being obstructed by the fact, right, that the mitral valve, the valve that regulates, right, blood flow from the left upper to the left lower part of the heart, makes an abnormal motion during the ejection phase of the heart to then obstruct the blood flow about midway through that ejection phase. And when that happens, and then my analogy is like when that happens, it's like, you know, when you sort of clamp down on a water hose or a garden hose, water backs up. And when water backs up, you know, it increases pressure. And that's the same thing that happens here. When that mitral valve comes over, it touches the other part of the heart, the thick muscle, to obstruct blood flow. The consequence of that is that it creates extra pressure in the heart, what we call a pressure gradient. Higher pressure in the heart than out of the heart. And that's the pressure gradient that patients get told sometimes when they get, you know, during visits. That's the other number being produced by the valve touching the septum during the mid part of the ejection phase. So that's what obstruction is. And I'll make one other comment is that, you know, what we've learned over the last several decades is that pressure produced by the mitral valve is really the strongest determinant. It's the most important reason why patients with HCM can develop symptoms like, most commonly, shortness of breath with exertion, particularly with inclines like stairs or hills, but also chest pain, decreased exercise tolerance, palpitations, etc. So that's why those symptoms occur, because of the high pressures. And that is why, and then we'll open it up, but that's why the obstruction is a very important target for treatment for those reasons.
Great explanation. I carry a sample of a heart in my hands, and I use them as tools all the time. And if you're watching, I gotta move my microphone. A normal heart should have this much room in it. An HCM heart may have a little less room because there's thickness. If the valve is opening up, it shouldn't be hitting any other apparatus within the heart. Right. In HCM, we're just making this connection typically. That's the most common form of obstruction. There are other forms, but that connection, not a good thing. The blood is blocked into the heart, pressures grow, and there's downstream consequences. And I think for many years, we pushed off those downstream consequences because therapies were invasive and drugs weren't working so well. But now we really understand how important it is to get rid of that abnormal blood flow. That a good explanation?
Yeah, I mean, exactly, because when it is obstructed, the blood flow, it over time is responsible for patients starting to feel those limiting symptoms that ultimately, as they progress, impact the patient's quality of life. Okay. And the other point there is that the obstruction, creating the high pressures that we were talking about, it doesn't put the patient's heart at risk of bursting or is responsible for an acute event. It really is an issue that goes to producing symptoms that then impact the patient's quality of life, which is obviously still very important. But that's really the consequence of the obstruction is symptom limitation.
So it's 2024. We have a new iteration of guideline. We have a lot of lived experience, a lot of clinical experience, and a lot of new options. I was explaining to somebody yesterday in social media how it's the best time possible to be dealing with diagnostic dilemmas in HCM, as we have more tools in the toolbox than we've ever had before. And there's a lot more options that can be short-term or long-term, depending upon your individual needs. So let's unpack the what can you do about obstruction? Like, what's the easy thing, and how complicated can it get, or how easy can it be?
Yeah. So maybe the first place to start there is to say that, there are patients that have obstruction who are asymptomatic, right? They don't have any symptoms related to that issue or at all, period. And for those patients, we may not decide at that point to treat them with anything at all, which is reasonable and fair still at this point, because again, the goal here in terms of treatment is not preventing mortality, it's improving quality of life. Okay. So asymptomatic patients with obstruction may require nothing. Okay. Now, if you've got symptoms that are attributable to those high pressures from obstruction, as you were just saying, we've got today in 2024 lots of different options that come down to sort of two buckets. You've got medicines and you've got invasive procedures. Okay, that's what we've got: medicines or invasive procedures. The medicines that we've got, and there's several, which we can talk about in a minute, but the medicines in general, the idea there is that they are working in a way, and they work differently this way, but the ultimate goal is that the way that they work is to kind of decrease how forceful the heart is contracting. And by doing that, you then limit or abolish the valve from coming over to obstruct blood flow. Okay? And when that happens, you can lower, or you can actually completely normalize those pressures that we we're just talking about. And when that happens, that's what makes patients feel so much better. Okay? So that's what the drugs are doing. But they're doing it in different ways. But that's what they're doing. And they each have, the drugs, different efficacy to accomplish that goal. And they each have different side effects and downsides. And so and then that has to be put up against the invasive procedures, which are surgery, called the myectomy, which is open heart surgery. And we've got a catheter-based procedure called alcohol septal ablation. So those invasive procedures change the anatomy directly. The drugs don't change the heart anatomy. They alter the force of how hard the heart's contracting to lower the gradient. The invasive procedures are actually changing the heart anatomy to accomplish that goal. Okay? So those are the two big differences between drugs and invasive. So do you want to talk a little bit more about the drugs themselves and what?
Let's talk about the longer use. Let's talk about roller beta blockers as it exists today and as it may evolve. and then let's kind of build up from there, because that's kind of our baseline.
Yeah, I mean, I think, yeah, exactly. And I think, and again, the way we approach this is usually to start with the drug that's been around the longest, probably, and it has, in a way, the least side effects, but also it may not be the most effective either. But it's a reasonable place to start because many patients still get benefit in their symptoms from this drug, which is beta blockers. That's the class of drugs that we're talking about. Beta blockers, again, they decrease how forceful the heart contracts. And by doing that, they lower the gradients in patients. And by doing that, again, patients feel better. The beta blockers, probably the two limitations there are, one is that they're often not effective enough to relieve the symptoms in a way that satisfies patients, or they can cause side effects. Mostly that's fatigue. Sometimes for men, that's sexual dysfunction. And so they are limited in their ability because of side effects as well there. But they remain, because they're overall safe, the first starting point for drug therapy.
So beyond a beta blocker, and I'm going to give a tease for next week's podcast, we are going to be talking about, with Dr. Harry Lever and possibly another guest, quality of generic drugs, and we actually have some data now. Yeah. And my props out to the DoD for doing the work. And we're going to report on that next week on Tales from the Heart. So if you want to hear about what's happening with drug quality testing in the United States and what the Department of Defense has actually done and proven, that's a teaser to join me next week. And we're going to take a deep dive into that. Yeah. So there are safe generics. Congratulations. But there are very unsafe ones too. So we're going to talk about that. So beta blockers as base therapy, good quality drug, trusted source, right, consistent use, all good. Has side effects. Most of us don't like being on beta blockers. So for now, it's good, yep, but I think we can do better. When do we add in calcium channel blockers to address obstruction, or do we at all?
Well, yeah, I mean, some expert centers will also consider, if beta blockers don't work, switching to what's called a calcium channel blocker. Usually the most common of those is something called verapamil. Sometimes diltiazem. Those are the two calcium channel blockers. I say that's not unreasonable to try. My own personal view is that the efficacy, the ability of the calcium channel blockers to be helpful here in improving symptoms is less usually than beta blockers generally, but they're better tolerated. They don't cause fatigue or sexual dysfunction, so they're actually pretty well. They're a little bit better tolerated. Again, an old drug, so it's reasonable to try that, but with the expectation that for most patients, they don't really provide enough improvement.
In 2024, what do we do next?
So then at that point, and this is, again, a strategy, one that we employ here at our center, but also reflects, the current, recommendations in the HCM guidelines, the American Heart Association guidelines for HCM. Mm-hmm. The recent iteration of that, I should say, published, I think, within the last year. And what that document says, and also again reflects our practice as well as probably many expert center practices, that at that point in the road, patients really have a couple options. They can be offered another drug which is old, called disopyramide or Norpace. Okay. Mm-hmm. Let's talk about that for a second. Old drug, it's been around for decades. It's actually a drug that's an anti-arrhythmic drug. We're not using that. We aren't using it here for its anti-arrhythmic properties. We're using it because one of its properties as well is that it, again, decreases how forceful the heart comes together. And for that reason, it can lower gradients. And so it's another medical option. It's been around for a long time, and therefore we know really well about the drug's efficacy and safety. And so it has a greater effectiveness than beta blocker or calcium channel blocker at improving symptoms. It can have side effects, though. Those include mostly things like dry eyes, dry mouth, and for some, people that have men that have prostate problems, urinary retention sometimes. Those are the three most common issues. Those are nuisances, of course. They're not, showstoppers for some patients, but they're a nuisance, so they can be a bother. So that's an issue. Perhaps the biggest problem is that with Norpace is that it has limited what we call longer term efficacy. So what that means is that there may be patients, there are a lot of patients that get benefit. They feel better with the drug initially, but that benefit wanes and the patients go back to feeling the way they did before Norpace. Okay. And that benefit duration could be anywhere from months to years, but it can often disappear. Okay. And then there's about a third of patients who get started on Norpace who get no benefit really even out of the gate. Okay. So those are but again, reasonable option, very safe otherwise, and relatively cheap, okay, in terms of cost.
The one thing I'll say about Norpace versus disopyramide, the Norpace CR is a controlled release long-term drug, and it seems to work a bit better than disopyramide generic, which we find that the dosing period may vary based on the compound. Yeah. So it may need to be taken multiple times per day, which can be a little cumbersome. Right. There have been supply chain issues with Norpace CR in the past. We hope that they're over because there are a number of people who really do benefit from the drug, and we want to make sure that it remains an option for them going forward.
Yeah, and yeah, so thanks for bringing up the supply chain issue, which has been frustrating at times in the past for patients and physicians. Looks like it's, I hope, been rectified, hopefully. The other thing just to mention with Norpace too is that the monitoring for that is fairly straightforward and simple. It's usually periodically getting EKGs just to make sure one of the intervals on the EKG remains normal. But other than that, there's not a lot of monitoring associated with it. And you can start it usually for most patients as an outpatient. You don't have to be admitted or anything like that. Okay.
That has changed over the years. So people who've been on it for a long time may have started in the hospital, right. But you can take a dose, go to your doctor, get an EKG, maybe come back the next day, get another EKG. For most people, that's a safe way of starting, correct?
Correct. That's right. Okay. Yep. So pretty easy to use, in other words, as well.
In comparison to what we have currently out there, it's a little easier.
That's right.
Okay. So what other drugs are we using?
Yeah. And then the other drug option at this juncture in the road with beta blockers or calcium channel blockers, again, haven't sufficiently relieved symptoms or patients have had side effects with those meds, is a cardiac myosin inhibitor drug. Okay. And the one that's approved by the FDA for improving symptoms for obstructive HCM at this time, the only one approved at this time, is mavacamten or Camzyos. That's a drug that's new. It was FDA approved about 2.5 years ago for this reason. Okay. And it works, in a different mechanism, different way than the other drugs that we've talked about, but the goal is still the same. It decreases the contractility of the heart. And it probably does that in a more in a more profound and robust way than the other drugs that we've talked about. Okay. So that efficacy is probably better than the other drugs, meaning the degree of improvement for patients is higher with mavacamten than compared to Norpace, beta blocker, or calcium channel blocker. Okay, so that's good. The side effect or the downside is that mostly in a small percentage of patients, they can experience with the drug mavacamten a decrease in the heart's pump function that is too much, more than we would like to see. Okay, and when that happens, that could put a patient at risk for other adverse complications. Okay? And it's for that reason that the FDA mandated that patients who go or elect to go on mavacamten have to agree to be involved in what's called a REMS program, risk mitigation strategy, essentially, which means that what they do is patients that have to be followed longitudinally after starting the drug with echocardiograms more frequently than usual to make sure that heart pump function doesn't go too low on the drug, and to make dose adjustments based on the results of the echo to balance between getting those patients the right effective dose to improve symptoms, but maintaining safety by not dropping the pump function too low. Okay? And so there's a commitment, essentially, for patients there that's different than the other drugs for following with their provider. Right now, that includes an echo once a month for the first 3 months after starting the drug. And then it's usually about every quarter having another echo every couple months. Then after that, having an echocardiogram. And at this point, that frequency every couple months for echoes is indefinite right now. Although it could change, the frequency could change in the future with a modification of the REMS program by the FDA. But at the moment, it's indefinite.
So that becomes a challenge for patients to be able to, every 30 days, get to their center, get an echo, get to a physician. Maybe it's not going to be managed from their center of excellence, but maybe a community physician can do that screening. There are logistics, there are costs, there are inconveniences with that process. But we definitely hear reports that the outcomes, the quality of life improvements for a large number of people are worth the inconvenience at this time. But they would hope for a day where it was a little easier to prescribe and to manage. And I think we all hope for that day. So there's some new things coming down this pipe as well. And there's a second-in-class myosin inhibitor. And some data was just released last week at ESC in London about a study that was comparing removing beta blockers and keeping beta blockers and what the differences were. We're going to talk a little bit about what aficamten is and what we might be learning about the future of how to manage somebody on myosin inhibitors.
Yeah, so aficamten, as you just said correctly, is a second-in-class drug within the cardiac myosin inhibitor class of drug. So it's the one to follow mavacamten in a way. It's still under investigation. So what that means, just so everybody is clear, is that it's not approved yet by the FDA. It's under review. Okay, so it's not available. And where we are with that is that it just that investigation of aficamten was a investigation that involved a big phase 3 clinical trial that was presented a couple months ago. So brand new trial that was presented in patients, again, with symptomatic obstructive HCM, same kind of population that mavacamten was initially studied in as well. And what that study showed was that aficamten was very effective at improving symptoms, also making patients function better. So exertional capacity was improved, as well as patients feeling much better. Okay? And that the incidence of the heart pump function going too low was itself very low. Okay, very low, not zero, but very low. Okay? And also importantly, in those few patients on aficamten that had a pump function that did decrease, those patients didn't have symptoms from that. I didn't get sick from it. It was reversible when you didn't actually. Let me say, you didn't have to stop the drug even. You just had to adjust the dose. Okay, So it didn't result in any, treatment interruption at all. Okay.
Okay.
So that's an important point because that's a little different than what's been seen with mavacamten. Okay. And so, as part of that investigation, as you were just alluding to, just recently, just last couple weeks ago, there was an additional study showing that, because aficamten was so effective at making patients feel better, it permitted the opportunity in patients to come off of the beta blocker or calcium channel blocker or even Norpace if they were on that to begin with, before the aficamten was added on in the study. Okay? So what that means is that this drug may provide the opportunity to give patients a great improvement in how they feel and how they function, and in the process, potentially get those patients off the other drugs and still maintain that benefit.
So what I would,
by the way, which is really important because, of course, patients, want to lots of patients want to come off beta blockers or disopyramide because of some side effects.
Yeah.
And so the opportunity to do that and still feel great, that's a big advancement.
I was very taken with the slides that showed the symptom burden on and off beta blockers after being, brought up to optimal therapy with the myosin inhibitor, and then you're dropping out the beta blocker. There was no difference in those two groups. There's nothing statistically different, like nothing.
Right.
And that's amazing.
That is, that's right. I mean, and I think that reflects that beta blockers are just probably also not that effective, for most patients, unfortunately. So, really important data. I think the other point about that is that there's another study that is not completed yet with aficamten that's actually going to look at aficamten versus beta blocker as first-line therapy. It's called MAPLE, MAPLE HCM. Yep. And so that's, all these acronyms I get confused. So, and so that study is unique. Again, we don't have the results of that yet. But if that study is positive, meaning it shows that you can safely and effectively start aficamten as initial therapy in a symptomatic obstructive HCM instead of a beta blocker, that also changes our paradigm here about our strategy for treatment here as well. So that's something to look forward to in the future in terms of even more information and data coming out about this new drug in obstructive HCM.
So I'm going to take all of that great information about all of these strategies to reduce gradients and improve obstruction and add a layer on top of them. These decisions on which tool to start with and which anatomy is more likely to respond and which patient, based on other aspects of their profile, are likely to respond to each therapy are really still being defined by the highest level centers in the country. And I cannot state strongly enough two facts today. Number one, high volume matters. Whether you're starting a myosin inhibitor or you're thinking about surgery or alcohol ablation, you need to go to a team that can assess and then a team that can deliver the therapy at the highest level possible, keeping you, the patient, as safe as possible. I'm perplexed, and I'm going to keep this agnostic as to center and person, but I'm dealing with somebody who's got some really negative consequences of a surgery done not in a high volume center, and we're now having problems in that they're not getting to answers. If you're really struggling, please get to a high volume center. We have the Lori Fund available to anybody in need of travel assistance to get a second opinion if they need one. Some virtual concepts might be available too, depending upon where you are in your insurance. But please check.
Yeah. So let's also maybe, because I don't want to run out of time without having the opportunity here to make the points we also want to make about invasive options here,
Yeah.
right? Which is, surgical myectomy and alcohol septal ablation, right? And look, I think a couple points is that there's a lot of enthusiasm, rightfully so, of course, for the new drugs and their impact here. But I think we also want to make sure that it's clear that what that doesn't mean is that the surgery and the ablation are going to be completely replaced or taken away. That would be one, not right, but also a shame, because they are also, for the right types of patients, incredibly effective still, and will remain that as the treatment options for obstructive HCM patients. Okay? And what to clarify a couple of things about that, first of all, there are some patients that don't completely improve on the myosin inhibitor drugs. Okay? And one of the reasons that may be the case is that patient's anatomy in their heart is such that the obstruction can't really be totally eliminated or improved with a drug. They need an actual invasive procedure to change the anatomy to get that benefit. Okay? Another reason why it's really important to visit an expert center here, because the expert centers really understand these important issues, and for that reason can help direct sometimes patients to the right treatment options here based on these kinds of really important points. Okay.
Mm-hmm.
And I'll also say too that in addition to the anatomy being important here and potentially again making these invasive options still really important, I'll also point out that there are a fair number of patients too, at least based on my experience, who have a personal desire. They have a personal desire to choose an invasive procedure, for example, over a drug, because they really value the fact that they can have this improvement in symptoms with usually a one-time procedure, without then having to take a drug continuously, maybe in some cases for the rest of their life, which is a very attractive option for some patients, as long as they understand, and that can be very appropriate, as long as they understand that with surgery and alcohol ablation, they're accepting a small procedural risk with those procedures for a big benefit, again, huge benefit in terms of symptom benefit. That may be very appropriate for some patients. Okay. And so I think the point here is that we are in a very, very exciting time where, lots of these decisions are individualized. It's an individualized decision-making process, not one, it's not a one-fit-all situation sometimes. Okay. And so that's one of the major points.
I think that's an excellent point. And when we're dealing with patients with HCM, no matter the topic, we're always the same but a little different. Atrial fibrillation management. We don't make the playbook for regular old AF. We're AF and HCM. So dealing with obstruction and anatomy, and everything's very personalized, whether your septum is a thing that's really thick, your apex is really thick, your papillary muscles are thickened or displaced. There's a lot of anatomy going on here. And that's why it takes directors of programs like yours to be puzzle solvers and people who like complex problems, because you can't just hit everything with the same hammer. It's not all the same nail. So we need to be personalized here.
That's right. I mean, people have the perception, patients are obviously rightfully have the perception that it's just sort of one disease. It is one disease, but that, they have to, what is sort of a complicated point is that there's an enormous diversity in the expression of that disease, HCM, in terms of anatomy. And that kind of diversity in the anatomy within an HCM heart does and can impact significantly on what may be the optimal treatment choice here.
So we have a question from the audience, and I wanted to bring it up on screen. Elon's watching us on Facebook. So he's saying several people, and I guess he's getting this from some of our discussion groups, have fallen EFs under 50 at the dose up to 15 milligrams. I think dosing is something that's kind of a red herring here because some are metabolizers and some are not. So dose numbers are not as important to me as they are whether you're a metabolizer or not. It appears that stopping and renewing, even on the lower EF, the EF pops back to 50. We talked about this briefly. I just wanted to answer his question and bring it home that yes, this is the experience of most programs, correct?
Yeah, I mean, yeah, there's no question that if the patient's ejection fraction EF, which again is a marker of the pump function, falls below 40%, and again, that's low. 40% for those that may not know, that's low. So when that happens, you got to stop the drug, and maybe again you have to individualize this a little bit, but you could restart at a different dose that patient. It also may be possible that for that patient they would not elect to go back on the drug because that was a pretty profound response with a low pump function. So again, to your point, that would be a scenario where you would really want to talk to your expert HCM provider to decide the best step if the pump function went that low on Camzyos.
Very, very well put. Is there anything coming in the future for the management of obstruction that you think looks promising?
Well, I think that there's, we're seeing, evolution, and maturation, on all fronts, right now, meaning that there's evolution and progress in the technique and catheters and approaches with alcohol septal ablation, for example. Okay. And there's also, evolution in surgery and how to approach surgery to make it perhaps a little less invasive and maybe even, a quicker, less invasive approach. There's evolution in the drugs. The drugs are, there's different compounds being looked at that, may affect the myosin, the structural apparatus of the heart, even in different ways than mavacamten and aficamten that may have different benefits and so forth. So this is an incredible time. There's all kinds of progress going on all fronts.
There are, and I will save it for another day, but these new twists on surgery, the sesame procedure, these newer approaches. We'll take a deeper dive into surgery at a later podcast. As we're heading to the top of the hour here, if anybody has any questions, they should post them now and we'll try to address them. But we've got some housekeeping to do, Marty. We got some things coming up this fall.
I know.
So I'd like to talk a little bit about what's coming up. So why don't you tell us a little bit about what HCM International Summit 8 is and how people can get involved?
Well, what we've got going on in the fall is a huge event. We've got I'll break it down into sort of two parts. There's the International HCM Summit, which is really the definitive scientific conference for this disease in the entire world. It's been going on for about 30 years. It usually occurs every 2 to 3 years. It's happening this fall in Boston. In person. There's probably going to be also an option of a virtual component as well for people to tune in. Yep. And that's a 2.5 day, almost 3 day event where the world experts in the disease are providing their insights through multiple different types of talks and panel discussions. And that conference is going to occur, in sort of almost in parallel in a way with your HCMA patient annual meeting. You want to talk about that?
Yes. So I'm going to be very tired by the time we come into dinner on Sunday night, but we will be coming to Boston on Thursday that weekend. Friday, we have, the onboarding of the summit, and we're going to get things rolling. And actually, Friday's all day summit. Thursday's when we have the welcome event. So we have science all day Friday, Saturday, and Sunday half day. And then while the summit is going on, we will be hosting HCMA at the summit Saturday night. So for all the participants of the summit and those of you who are patients who would like to join us for that event, you're welcome to. And you can register online for either Saturday night, or you can register for Saturday and Sunday at the HCMA annual meeting. And our program will start at 1:30 in the afternoon. At the conclusion of the summit, we're going to be having Marty and Steve immediately flip from the summit and give you, the patients, the highlights from the summit. They're going to have a top line talk where they're going to take everything into Cliff Note versions, for those of you old enough to remember Cliff Notes, and give you the science in a presentation. And then you're going to hear from other great speakers on different aspects of HCM. Then we're going to meet for a bit of a dinner that night. There will also be the opportunity for clinical trial rooms. You'll be able to go meet with the sponsors directly and learn about clinical trial opportunities. Those rooms will be available Saturday afternoon prior to our event Saturday night, and Sunday morning and Sunday afternoon. So you'll have an opportunity to learn about clinical trials, meet with your big-hearted friends, talk directly to the physicians that are on the panel. They want to talk to you, you talk to them. So we'll all be there together learning, hearing about what we can do to improve diagnosis and surveillance of HCM, using some new technologies like our friends at Viz.ai. I'll be doing a panel with them on Saturday afternoon as well. It's going to be a busy weekend. So we hope you all come to Boston for the fall and join us. It's Halloween weekend. I may have a couple of surprises up my sleeve for Saturday night at the summit. You're going to have to come and find out. And that means, Marty, you're going to have to come over from the faculty dinner for just a few minutes and jump in. It'll be fun. It's going to be inspirational. It's going to be really functional and understanding how we work as an organization in this ecosystem.
Yep.
And we're going to share some really amazing stories and have some patients there. And Barrett Haynes will be back. He is our singer who was on The Voice, and he's going to come back to join us to do some entertaining of our participants. And violinist Nori Hadley will be joining us as well, providing some entertainment that night. So it's turning into quite a fun event. So we hope you all join us. Next week on the 17th, HCMA is holding a medical education webinar on HCM and amyloidosis, how to know the diagnosis. And this is for medical professionals, but anybody's welcome to join, and you can log on for free. And we thank our sponsors at Pfizer for that opportunity to provide that education. We'll also be at HSFA, and we have a trade show booth. If you're going to be there, you can come by and see us. And simultaneously, we will be at the American Academy of Pediatrics in Orlando, talking about the importance of the Healthy Cardiac Monitoring Act. So we're hoping to educate the pediatrician population on the need for family heart health history screenings. And of course, we'll also be at the HCM Society meeting that's in concert with with Heart Failure Society meeting. So a lot coming up in the next month and a half.
You think?
And HCMA will be welcoming, hopefully, 2 new staff members for October 3rd in the capacity of intake coordinators. There's a lot going on here, and there's a lot more of you getting diagnosed. And we are trying to make it as easy as possible to onboard with us so we can align you with all of our resources and educational material and find your clinical care model that you like and your team that you like. And we are really scaling up to provide you with additional resources, and we'll be announcing some other big projects in the coming months, but we're not quite ready yet. Is that enough to do for a couple weeks, Marty?
God, you are going to be busy. Unbelievable. Take care of yourself.
It has been a wild, we really kind of started in May. With going to Lisbon to the Heart Failure Society, to ESC Heart Failure, and hearing the great data out of the CITO trials. Then we went out to ASE in Portland, and we were talking about how to do better echoes. And then we were in Seattle doing site visits, and we were doing other site visits that have come to wrap. I'm happy to tell you that we'll be announcing another center very, very soon. We voted on it at the board on Wednesday night, so we don't want to steal their thunder. We want to make it a nice announcement. So the South is getting a new program. Stay tuned. So lots going on, not a dull moment, and we're already planning our events for February and Heart Month. And we are planning to go back to Capitol Hill and have another briefing. So we are going big, we are going loud, we are going in to make sure everybody gets diagnosed, everybody has access to care, everybody has access to new therapies, and that we put the physicians and the patients at the front of the decision-making tree and keep the payer systems engaged and at the right level. How does that sound?
You need to add some more things on.
I got a couple other things that I'm not ready to announce yet either, but you're all going to learn about it in the next 3 months. So I will leave it there on this lovely Friday the 13th.
Right.
I wish you all a great weekend. Holidays are coming up. I hope you're all planning for your family functions over the next several weeks. And I thank you, Marty, for the opportunity to talk a little bit about 9/11 this morning. I hadn't thought about that for today, but it's just kind of important to keep all of these things in mind as we are trying to navigate through a very complicated world.
Sure.
And all trying to do our very best to navigate through that world, and sometimes with some challenges. And why I am going to create a new meme about the word pivotability. I'm making the word up. You've got to learn how to pivot in life. And when somebody throws something at you, you've got to learn how to stay resilient and keep on course.
Totally.
There's a lot of distractions in the world right now. And we are in a very good place in the HCM community with new therapeutics, new technologies, and new partners that are going to help us save lives in the future. So I can't wait to continue this journey with everybody, and super excited about what's to come.
Well said, as usual. Great to see you. Great to be with you. And with
Thank you so much.
And look forward to next time. Yep.
Thanks, Julie, on the back end. And thanks to Joey, our podcast editor. My best to Carl the dog. We love Carl the dog. And thanks to all of our sponsors. You can find all of our sponsors on our website. Without them, programs like this would not be possible. So we thank you all.
Yep.
And goodbye, everybody.
Good weekend.